Hello everyone, and thank you for joining us. I'm Dr. Gary Severance, and I'm pleased to present to you a special clinical update webinar as part of the weekly series from Henry Schein on COVID-19. Shortly, I'll be turning it over to Dr. David Reznik for his clinical update, but I wanted to let you all know that we are so appreciative of your comments and suggestions and questions that generate content for future episodes. Based on that, we wanted to step back just a little bit to let you know what has changed and give you the basic information on COVID-19, the virus. The virus is an airborne pathogen. It can be spread through contact and through aerosol transmission. Coughs and sneezes are most often mentioned for the general public. It can remain airborne for approximately 3 hours and travel up to 13 feet in air. That's up from the expected 6 feet originally. And it can live on hard surfaces for a few days. The virus is 0.125 microns in diameter, but it's normally carried by water droplets much larger than a micron. Now, all of this is important because dentistry essentially creates aerosols with nearly every procedure. The use of high-speed handpieces, ultrasonics, air-water syringe, all can create aerosols. Now, every dental office and their specialties have their own unique environment, procedure mix, and patient flow. So it's difficult to have one solution for the entire office or every office. Now, while dentistry with its PPE was probably the best prepared of the healthcare professions, it's safe to suggest that coming back, more will need to be done. There will be greater emphasis on ensuring patient and team member safety. And there probably will be the introduction of a new category, OPE, Office Protective Equipment. How can we reduce aerosols that are generated during the treatment? Any aerosol that escapes the mouth that we don't capture with high-speed evacuation, how can we eliminate that? Air purification, filters, scrubbers, etc. And because we want to minimize exposure to the patient and to our dental team, we'll probably minimize the number of patient visits. And doing so, we'll have to maximize production during each visit. So there's a lot to talk about, especially when we get into room turnovers, PPE, and what the office environment is going to look like in the future. One thing we do know, we have to control the patient flow throughout the entire office and throughout their entire procedure. Everything from waiting in the cars to waiting in a waiting room to getting back into the treatment room and out. Now, be assured that Henry Schein, along with probably all dental manufacturers, are comprehensively looking at how the products they offer or will offer or bring to market will help meet the expected and mandatory needs for the safety of the profession. Now let's turn it over to Dr. David Reznik for his weekly update. Thank you, Dr. Reznik, for joining us again.
Thanks, Gary. It's great to be back with you again this week to look at some of the different changes we have and little advances that have been going on since we spoke the last time. I'm David Reznik. I am Chief of Dental Medicine at Grady Health System in Atlanta, and I'm here to at least to talk about some of the things that we're seeing. And some of it is a little bit of conflicting messages. So I do want to take things back a little bit and drop things down to a level. We are not trying to create operating rooms. That is, we do have operating rooms for certain oral surgical procedures, but these are not hospital-based recommendations. We are an ambulatory care program that is trying to create a very safe environment for our patients, for the rest of our teams, for our families, but we're not trying to recreate an OR. And there were some certain questions, that I brought up, or certain things I might bring up that, well, when you look at some of the studies, you'll see that on the floor there's a great deal of the virus. And so I mentioned it might not be the worst idea to put on booties. Well, this really is just to protect your family at home. Because you don't want to track this stuff out of the dental clinic, and if you use a good air scrubber at night, the floors are probably going to be fine. So this is just some of those little things that are messages that I want to get across, and I love it when you ask questions and give me the chance to respond, because then everybody can be on the same page. We do have some conflicting messages that are going on even in the U.S. on some state level and some CDC levels, where some states like mine are planning on opening some limited services, including elective procedures on Friday. But I know that my hospital is not moving forward with elective procedures, and I'm not ready yet. And so I think what to take from the sections that I'm doing and others are doing on these webinars is, what can we do to make sure that we create a safe environment and can get back to work? I miss patients. I miss having the activities in my clinic that happen on a day-to-day basis. I love dentistry, and I want to get us back up and running as safely and as smart and as economically reasonable as possible. So, with that being said, there were some questions that pop in. Do I need to change my lab coat and mask in between dental hygiene exams? So if you're just going and you're doing exams on patients, you really don't need to change your normal standard precaution procedures. You're not going to be generating an aerosol by doing an exam. You don't have to change footies if you have them on. You don't have to change your lab coat had it not be soiled. If your mask is not soiled, there's no reason to change it. So it's basically, we just want to go back to routine kinds of dental care for doing exams. And so you don't need to change your footies. And then some of the questions that came up, I have to be honest, I'm learning a lot through this process of sharing information with you. I'm actually educating myself and trying to get my program ready to open up in a safe level as well. So when it comes to the different face mask levels, I will be honest to tell you, I did not know. And so I thought if that's the question that I had, maybe others would have that question as well. So we do have the ASTM face mask levels. ASTM internationally was formerly known as the American Society for Testing and Materials, is an international standards organization that develops and publishes voluntary consensus technical standards for a wide range of materials, products, systems, and services, and in this case, masks. So if you look, let's start at the bottom. The lowest performance of all of the masks are surgically molded utility masks. And that is the picture that's on the right. So those cone masks that you see are really the lowest performing masks that we have. Our level 1 masks are what we can use for exams, and those are our typical surgical masks. They have some fluid resistance, not as much as you can see a level 3. It's 80 milligrams there. The filtration efficacy, you can see how good that is, and then they look at flame spread, which they're all the same. And so as you go up on the different levels, you can see that the key is on fluid resistance. So ASTM level 1, low fluid resistance. ASTM level 3 has the highest fluid resistance. So you might have heard me talk about putting your ASTM level 3 face mask over an N95 to keep it fresh. So those are some of the things that we have. Also, if you don't have access to N95s or KN95s or any of the filtration masks that we have talked about in the past, and all you have is a level 3, it is considered acceptable. It's not my favorite because it's not as good at particle capture, but it is good for fluid and barrier capture. I also have to look at some of our, what are we doing? Remember at the beginning I said we're not turning our programs into operating rooms. That is not the goal. Even creating negative pressure for our dental offices is really going to be quite a challenge, and we will be addressing that as we move forward. just creating a safe environment is number one. But we look at CDC transmission-based precautions. Right now, remember, we play with standard precautions. That means we assume that everybody that comes into a dental office on any given day before this new pandemic, that they had a blood-borne pathogen. So all patients would be treated the same. That's why they became first universal precautions, then standard precautions. CDC also has transmission-based precautions. And for dentistry, this is going to be a little bit new. Now, we've known about contact precautions. That's why we wear gloves and gowns. We know about, droplet precautions. That's why we've been wearing shields and eye protection and surgical masks. Now we need to worry about airborne precautions. And that's the step that we are actually in the middle of our evolution. Remember we went from basically wet finger dentistry, only wearing gloves for perio procedures and oral surgery, to universal precautions based on blood-borne pathogens, to standard precautions. Now it looks like the next evolution in dentistry will be to look at how do we manage some airborne precautions? And as you can see, one of the issues that they have on there are the N95 respirators, because that's how we have to look at addressing this disease, because it does live in an aerosol. So we have droplet precautions, which are covered usually with our standard precautions, but these are all transmission-based precautions by touching something through droplets or through airborne. And the thing that's new for us is addressing airborne precautions. I'm going to touch on OSHA a little bit, on preparing the workplace for us to return and get back. And regretfully, we are considered a very high exposure risk job. If you look at some of the charts out there, it's the dental team is number one as far as people who are at a high risk job, just based on the fact we are so close to our patient's oral cavity and so close to the nasal passages as well. So the high-risk jobs are ones with high potential for exposure for known or suspected sources of COVID-19. But remember, there are a lot of people who have this infection who are either asymptomatic or pre-symptomatic and don't know it, and they're shedding a lot of virus at that time. So workers in the category that have to deal with these very high exposure risk jobs are, of course, healthcare workers, our frontline colleagues, our doctors and nurses and physicians assistants and nurse practitioners. Our physician extenders are pretty remarkable, who perform aerosol generating procedures. Now, I put a star by dentist, which is literally what I got from OSHA's website. And of course, this is all members of the dental team. We are very high risk exposure. It's due to aerosol. So that means the dentist, the dental hygienist, the dental assistants, if you have lab people in the office, your front desk staff, every member of the team that makes us as successful as we are, we need to protect. And so this list should really contain all of our members of our team, and it really becomes more significant when we are involved with aerosol generating procedures. So it's not like if I walk into a room with somebody, I'm all that concerned. But when I do get more concerned is with these aerosol generating procedures, which I have been talking about for some time. So there are certain kinds of controls that we can put in place. There's engineering controls. So the CDC recommends that patients with known or suspected COVID-19 or a person under investigation, they may have run a fever, they may have been exposed, should be placed in an airborne infection isolation room, if available. For most dental offices, we just don't have these kinds of rooms. So what we can do is put the patient in a an operatory, hopefully a closed operatory, mask the patient up and help if they're running a fever and help facilitate their access to medical care. This is one of those disease states like diabetes and HIV and cardiovascular disease and pregnancy, etc., where the medical dental integration on how we're going to manage our patients is really very important. So if you have someone that is ill and they're running a fever and it's not dentally related and they show up to your office, you don't want to sort of kick them out the room. You want to put them in maybe a private area, mask them up, hand hygiene, and ask if they've called their physician. If not, please try to facilitate the call to the physician, not just showing up, because in many places in the country, we're just beginning to open up. So we don't have a lot of isolation rooms, so we're going to have to come up with different kinds of engineering controls for us to create this safe environment. Because it's literally, I think I mentioned, I am building a new clinic. I asked for one negative pressure room, and the cost of that negative pressure room was extraordinary. Now, there are some devices out there that claim that they can turn your office space into a negative pressure room. I'm not here to sell devices. There are other people who are much more informed on these devices than I am, and so I would talk to my rep about those kinds of things. As far as engineering controls, look at some of the air purification systems that are out there. And that's what I'm talking about when you speak to your reps or people that you order your supplies from or your equipment people. There are chair-side aerosol extraction devices. There are some that are available now. There are some that aren't going to be available until July. You also want to look at air scrubbers or portable HEPA filter units so that they might run 24/7 and make sure that any residual aerosol has been dealt with. There's overhead air purification systems. There are air exchange rates that we really need to look at to see if we can follow. And a lot of our air scrubbers actually do have a certain amount of air exchange rates. I did put on the guidelines there for you, so you can click on this presentation later and look and see what the actual exchange rates are based on what procedure that you're doing. So again, this would be considered as an engineering control. There are administrative controls that we need to look at via OSHA. So what are some of the things that we can do that will help protect our staff? And that could be our pre-visit screening calls, where you ask about the most common symptoms. Are you running a temperature of 100.4? Are you having shortness of breath, a dry cough, recent aches and pains or myalgia, recent diarrhea, recent onset diarrhea. And of course, one of the newer kinds of signs and symptoms is loss of smell and taste. Now, one of the things that's interesting about the loss of smell and taste is we do see that with other viral infections. So right now, since the flu season is sort of over and we're just dealing with COVID-19 for the most part, that is a good, helpful diagnostic sign. But if you look what might happen in fall when flu season comes back, and maybe we don't have a vaccine, because that would be a remarkably quick turnaround to develop a safe vaccine for human consumption, that we might end up having some issues with determining what is the flu and what's not. So, but right now, if they come in with these symptoms, again, if you do these calls, you pre-screen, you have a little script that's set up, and then you can ask, and if you get positives on any, please advise the patient to call their primary care provider and reschedule your visit until they're symptom-free. If someone does come in the office, and you get another question to ask, is there someone who is actually sick at home, or if they're not feeling well? And if we do have somebody that does present, again, as I mentioned, with symptoms, go ahead and mask them. Make sure they get their hands washed. And then remember some of the things I talked about really early on is we're taking our infection control a little bit, hopefully just a little bit more seriously. But now, after that patient, and we're going to wipe down the hard surfaces in the waiting area. Remember, we're not going to be dealing with as many magazines. because we're going to toss those. So the whole object here is to make sure that we keep our waiting areas as clean and as possible. Provide all workers with job-specific education and training, so how to properly fit the mask on. Doffing and donning would be important. Hand washing. Hand washing is our number one way of reducing hospital-acquired infections and healthcare-acquired infections. So make sure that we're mixing up the 20 seconds that we hear that from the United States government on how long you should wash your hands and other governments, and then look at the WHO hand washing guidelines, which really shows you more how to. So you get the outside parts of the hand, you get the areas of your thumb and so forth. And remember that this disease is impacting people of all different kinds of backgrounds and family members. And so make sure that you have some psychological and behavioral support available for your employees should there be a personal crisis in their family, or a member of their family becomes ill, or God forbid, someone passes. And then another thing that we can look at is our personal protective equipment, our respiratory protection. N95 respirators are always going to be the number one thing that we want to use. There are some alternatives that we covered last week. The KN95, which is actually made in China. There are also other kinds of filtering face pieces if we can't find what we're looking for. The elastometric half mask or full face piece, or the air purifying respirators, which are the PAPR devices, the powered air purifying respirators. These are something we could look into, although the PAPRs do appear to be sort of bulky and in the way, but my ENT surgeon friends are using them now without problem. The other thing is, it doesn't just need to be an N95. It can be higher. There are greater protections out there, and we'll talk about that. And NIOSH does maintain a searchable online version of their certified equipment list. So these are approved by NIOSH, which is important. Again, looking more at the personal protective equipment, some of the things that we look at are the alternatives. And so I'm showing you the different numbers here. And remember, I'm learning just the same way that everybody on these webinars is learning. I really never knew what the N stood for, or the R stood for, or the P. So N is not resistant to oil, R is somewhat resistant to oil, and P is strongly resistant, or it's oil proof. Remember, in early March, the FDA did issue an emergency use authorization allowing certain non-medical N95s to be used in medical environments. So there are different kinds of devices that are listed here. And just to give you an idea that if you can get an N99, go for it. But N95 is what we're recommending. I also wanted to talk about just the PPE personnel for N95 or higher respirator, which is on one side of the screen. You can see the face shield is on there, or they could have goggles. I'm a big believer in face shields just because I've been doing this so long. And when I first started wearing face shields, I was amazed at the amount of splatter that was actually showing up on the face shields. One pair of clean, non-sterile gloves. You can wear two if you're worried about how you're going to take off the clothes, and of course your gown. Here we're going to be wearing the footies. Remember, just because a lot of the virus can be on the soles of your feet, and I don't want to trape it through the rest of the building, or in my car, or in my home. Now, an acceptable alternative PPE is using a face mask, not a respirator. But this would have to be a level 3 or up. Face mask with the shield and the glasses. And I'll be frankly honest, I really would prefer that we use the respirators just because of the aerosolization of COVID-19 and the possibility of transmission. But if we can't get them because there's shortages, and this is an interesting time in our world's history, then there is alternative acceptable PPE that does require using a face mask, and you can find that on CDC's site. And so where are we? We know a vaccine is going to take some time to develop. And so we really are, there's a lot of interest out there on what treatments might be used. And so the experts of a U.S. panel did come up with an NIH treatment guidelines this week. And they will be updated as often as new data are published in peer-reviewed journals. I have worked with researchers for almost 30 years, and I have never seen a situation where non-peer-reviewed papers were making it into the press or making it into the internet. And it makes me sort of doubt the veracity of some of these things, because peer review is a really important part of what we do and how we move forward. So the guidelines are going to look at two categories of therapies used by our colleagues in primary care, which would be antivirals, which can actually target COVID-19 directly, and then host modifiers or immune-based therapies, which may influence the immune response to the virus by directly targeting the virus, which would also be very welcome. So we're looking at different mechanisms of addressing treatment, but presently we don't have anything that is pre-procedure. So right now, the treatment panel, the guidelines does not recommend the use of any of the agents for pre-exposure prophylaxis. Remember, pre-exposure prophylaxis is a big issue when we're talking about HIV disease, that when somebody is taking their pre-exposure prophylaxis, they cannot sexually transmit HIV. Do we have something that would be a medication that would prevent transmission of COVID-19 at the present time? And regretfully, right now, the answer is no, we don't have that yet. The panel also does not recommend the use of any agents for post-exposure prophylaxis. So, and when we're talking about bloodborne pathogens, we have a needle stick or an instrument wound or something happens during treatment. Exposure to SARS-CoV-2 would be sort of, could be, did somebody sneeze on you, et cetera, et cetera. So we're just not quite there at this time. The panel does not recommend additional laboratory testing or no specific treatment for persons who are asymptomatic or pre-symptomatic. And remember that could be a really high number, that of the 600 people on our aircraft carrier that tested positive, 60% are asymptomatic. And that really becomes the concern. It's just not watching out for the person who has bad cough etiquette. It could be somebody, 6 feet away in the grocery store line who doesn't know they have this disease, or who walked by you or whatever. So remember, there's a big issue we have with people not knowing their status. At present, no drug has been proven to be safe or effective for treating COVID-19, no matter what you might hear on the press. There is just insufficient data at this point, but this group will be looking at it on a fast-tracked method, and we really are just looking at some of the immunomodulators therapies at this time. So these are all recommendations, these are treatment guidelines, but we're not quite there yet. So again, what I really wanted to stress today is we are making some changes. This has been a remarkably difficult time for our profession, our incredible profession. But if we just look at addressing airborne transmission concerns, which aren't going to involve completely redoing your office, but may involve the purchase of some equipment. And I know how tight money is these days, but we have to reopen in a way that is safe for our staffs, for our team, for our patients, and for our families. And I'm very thrilled that Henry Schein is putting on these webinars so I can at least share a little bit of information to hopefully make restarting your practices sooner rather than later a reality. So thank you for your time and attendance, and back to you, Gary.
Thank you, Dr. Reznik. Again, each week you bring us valuable information, and we appreciate all the research you do to bring this to our viewers. If you have any suggestions or comments, you can email us at webinars@henryschein.com. And certainly, please subscribe to our YouTube page so you get notifications on all the new and relevant information. Until we see you again, please stay safe and stay informed.